So hi guys and welcome to this session. So in this session we are going to discuss about neurology and nervous system. So very important topic not only for your Norcet exams and all of your exams which are nursing related exams. You will be getting definitely 3 to 4 questions from this single topic. So I have concised all the topics of neurology related. So let's begin our discussion. Like neurology is very important, GCS, skull fractures and all. So I will be teaching about each and every aspect. So I have integrated the sessions, like I will be covering anatomy, physio and your medicine related aspects, MSN, surgery and pharmacology and all. So in this session, so let's begin our discussion with the neurology today. So let's first topic is like skull fractures. Very important in your IBQs are all been asked. So if you take the skull fractures are basically they are divided into 3 types, that is anterior cranial fossa, middle cranial fossa and posterior cranial fossa. So let's discuss like each and every point related to this. So in this anterior cranial fossa, where is the fracture? So the fracture occurs in cribriform palate. Okay, cribriform palate. So whenever there is a fracture over here in the cribriform palate, so you will get this kind of an eye. So look at the diagram carefully. So this is known as black eye. So look at the eye texture over here. So how does it looking like here? It's like completely black, no? So one eye is like completely fine and one more eye is like completely black over here. So this is known as black eye, or it is also known as raccoon eye. Okay, so this is black eye. It is also known as raccoon eye. This is about anterior cranial fossa, very important. So this is the most common. Anterior cranial fossa is most common when compared to your middle cranial fossa and posterior cranial fossa. And this is one of, and one more sign you will get is your CSF will get leaking from your nose. That is known as rhinorrhea. Nose related is something rhino, no? And like CSF is coming from the nose. That is known as CSF rhinorrhea. Okay, and you will get bleeding from the nose, epistaxis. So cribriform palate is something like if anybody is hitting over here, no, like if anybody you punch over here, so over these areas, and like you will be getting this black eye or this periorbital swelling, no, like near your eyes, that is known as periorbital swelling, or that is raccoon eye or black eye. And one more sign, what is this? One of most important IPQ, they have been asked in your previous exam. This is also known as halo sign. So why it is done? It is used to differentiate whether it is an epistaxis bleeding or it is a CSF rhinorrhea. So if I take the tissue paper and I will put this CSF rhinorrhea on this tissue paper and I get this, no? So this is centrally there is a blood and peripherally there is a white substance, no? This is your CSF. This central part one is blood and this peripheral part is CSF. So this is an best example of CSF rhinorrhea to differentiate whether it is an CSF rhinorrhea or epistaxis. Okay, this is halo sign, very important. And this is about anterior cranial fossa fracture. And if the fracture occurs in middle cranial fossa, that is your teres part of your temporal bone, that is middle cranial fossa, basically where the fracture is occurring in your teres part of temporal bone. So where you will get all ear manifestations. So look at this. So this is known as, so look at the redness behind the ear. So anteriorly like eye, that is raccoon eye. This middle it is like teres temporal part, that like redness is seen behind the ear. So that is called as battle sign. So this is your battle sign. And what do you mean by this? This is nothing but discoloration over where? Over this mastoid region. Discolorization over mastoid. Okay, and that is like accumulation of blood in behind the ear, that is known as hemotympanum. Tim, tympanum. Okay. So here the CSF will leak from the ear, that is known as CSF otoria. Very, very important. Like rhinorrhea is anterior cranial fossa and middle cranial fossa is CSF otoria. CSF otoria. That is CSF is leaking from the ear. So this is about signs in middle cranial fossa and posterior cranial fossa. Like if the where is the fracture occurring in posterior cranial fossa? In occipital bone. Occipital is something which is related to your vision. So here the fracture is occurring over the eyes, though that is known as occipital. So this is your visual problems. So which is your sixth nerve injury occurs over here. This is about very, very important skull fractures. All this raccoon eye and this about battle sign, CSF rhinorrhea, CSF otoria are like frequently asked questions. And these IPQs are very important. Okay. And which is most common is anterior cranial fossa fracture. Okay. In among all the three. And this is about skull fractures. And next, very important, brain injuries. Like brain injuries are divided into two types. One is primary and secondary. Primary is nothing but due to impact, and secondary is mainly due to raised intracranial tension. Due to rise in ICT. ICT is nothing but intracranial tension. Okay. And let's discuss primary disorders. What do you mean by this concussion? Concussion is nothing but like why? So suppose imagine the two they are playing in football or something basketball, and both the players they had a collision between each other, and one of the player he fell down, and after like within like 10 seconds he has woke up, and everything is for 10 seconds he went for unconsciousness, and again he woke up, and again he's playing the football, nothing is happened. So like what is happening, there is violent jerking, violent shaking of the brain, so that is known as concussion. So concussion is nothing but like whether the two person had the collision, and after some time he got the for some particular period of a time he is unconscious, and later he become conscious, that is known as concussion. And what do you mean, so what is the treatment over here? Like nothing, it is a self limiting. So nothing is, the patient will become conscious within an over a period of a time. And what do you mean by this contusion is, contusion is nothing but collection of blood outside the blood vessels. This is about concussion. So concussion is nothing but only like jerking, violent jerking or shaking movements of the brain, so that is known as concussion. Contusion, there is a blood accumulation outside the blood vessels. Okay, this is about contusion. This is also like self limiting, and no, like if any give like bruising occurs, no, like if anybody they will give punch over here and like over here or over the ear head and all, like we will get a bruising over here, and like it's a self limiting. So this is about contusion. And next is like diffuse axonal injury. Remember, this is an worst and this is the most severe form, and prognosis is worse. GCS will not at all improve over here. This is known as diffuse axonal injury. Why it is occurring? There is a shearing force is present between the gray and white matter. Okay, so how does the patient will present? Patient is in coma, and GCS will not at all improve in this patient. GCS is not improving. Okay, so this is about diffuse axonal injury. So so whenever a head injury patient come to an emergency, so like first we are going to basically we are going to treat him, and then we will order a CT, that is non-contrast CT scan is always done in head injury patient. But after that, why we have to do that CT is like if you do the CT scan, we are able to differentiate whether is I will teach you in upcoming slides, that is EDH or SDH and all. So like what you will do is like if you do this CT, we are going to know like whether what are all the head injuries are present. So I did a CT in this patient. So remember, diffuse axonal injury, your CT scan is normal, absolutely normal. So that's why here investigation of choice is MRI. over in this condition. Okay, this is about diffuse axonal injury. And next, very important, we move to this condition, that is EDH. So extradural hemorrhage or epidural hemorrhage. EDH is also known as extradural hemorrhage or epidural hemorrhage. Extradural or epidural hemorrhage. So why it happens and what actually happens over here is, imagine like an young guy, and he got a very good marks and he took a very new bike, and he's running in a very fast at 70, like 120, 130 and all, and definitely like he's not wearing the helmet and he got a road traffic accident. Then like there is the damage to this artery. Which artery? This is an arterial bleed. Remember, this is an arterial bleed. Which artery in the brain it is going to bleed? M M A. What is the full form? Middle meningeal artery. Middle meningeal artery. If there is a damage to this, then the person is coming to the hospital with this EDH. So in this EDH, very important is nothing but your, how the clinical feature is lucid interval. So I will explain you very important. Lucid interval is like, the person has fell from the bike, and after some time he got awareness, and at the time of falling he is unconsciousness, and after time he woke up and he came to the home, and in the home, and he was like, he told that like, I had a very accident, and after some time I was like perfectly normal, and he driven the bike until the home, and in the home again he become unconsciousness, right? So the period of consciousness between the two unconsciousness is known as lucid interval. Okay, period of consciousness between two unconsciousness is known as lucid interval. Lucid interval where you are going to see is EDH, and after coming home he again become unconsciousness, and at bringing to the emergency gate the person got explained, so that the person got expired. So that's why this condition is very dangerous, no? So like this is very important. And after coming to the hospital, like he's completely, and his friend brought to the hospital, and I have ordered a CT. So investigation of choice in any head injuries, non-contrast CT scan except diffuse axonal injury. Okay, so I did a CT over here, and look at this shape. So this is about biconvex lens shaped hemorrhage. So this is biconvex lens shaped hemorrhage. Is found in which? In extradural or epidural hematoma. Very important. So this is about EDH. Young guy, the examiner always the young guy driving without a helmet, and he got an accident, and the lucid interval is present. Lucid interval, you know, unconscious, and again he's perfectly went to the home, he alone rode ride the bike, and again he got the unconsciousness at home. This is about lucid interval. Okay, and imagine, so I will teach you all the types of bleedings like EDH, SDH by through this single line. Suppose this is dura mater, this is dura mater, this is arachnoid, and this is pia mater. Okay, so epidural hemorrhage is nothing but bleeding that occurring above the dura mater. This one above, epi is something which is above, no? So that's why the bleeding is occurring above the dura mater, that is known as epidural hematoma. Which is which artery? Very important, middle meningeal artery. Okay, if the bleeding that occurs below this, below the dura mater, that is subdural, and above the arachnoid, that is subarachnoid. So sorry, this is like subdural. The bleeding that occurs below the dura mater is subdural bleeding. No, that is known as subdural hematoma, that is SDH. Epidural hematoma, this is EDH. If the bleeding, same bleeding, it occurs over this below the dura mater, that is subdural hematoma. Here veins is present. Which veins? Bridging veins. So like if there is any damage to these bridging veins, that leads to subdural hematoma, SDH. Okay, and next one is SAH. So this is an arachnoid. Anything below the arachnoid is subarachnoid hemorrhage. So here what is present here is Barrett's aneurysm, and it is also known as like which artery. This is also an arterial bleed, that is MMA, and this is MCA, middle cerebellar artery. This is middle cerebellar artery. So this is about bleeding in an SH, and very important. And here Barrett's aneurysm is there. No, if this Barrett's aneurysm, it will get rupture. So that leads to subarachnoid hemorrhage. These are all very important. And now I will be teaching about one by one. So like what is the treatment over here for EDH? So now we are discussing about EDH. Don't forget that. And what is the treatment over here is craniotomy or burhole. So remember, so whenever a head injury is present, the person like he's completely fine, and he got fell down in the home, and he developed this posture, that is decorticate, flexion of an hand, and after some time he develops into decorticate and decerebrate position, there is extension. So this is an posturing. These are all abnormal positioning, decorticate and decerebrate. I will be explaining. But what is the treatment if the person has came to an emergency and he got this like decorticate or decerebrate position, you are going to perform burhole in that procedure. No, burhole is the preferred method if the person developed posturing, and if the best method of EDH management is craniotomy. And next is subdural hemorrhage, and this is about venous bleeding. I thought you know about the diagram which is involved bridging veins, that is bridging veins are involved. So I am explaining clearly so that you won't get forget. So look at this CT, the CT over out this is looking like, it is looking like a lens, no? This is a lens shaped or concavo convex shaped, or it is also known as crescentric hemorrhage. Trick hemorrhage. Very important. So how do you manage this? Management over here is craniotomy. Okay, very important. Subdural hemorrhage, epidural hemorrhage. So here like how you will in subdural hemorrhage it occurs in an old, like I cannot tell an old age. Suppose imagine an young like a old lady, and she felt in a bathroom, and after that she woke up, she alone, she woke up, and after some time she is completely fine for 1 to 2 days, and after that she developed an headache, and later on she developed these neurological manifestations. So this is like progression, bro. So this is like it will take some time. So this is about subdural hemorrhage. And like what do you mean by this subarachnoid hemorrhage, which is going to rupture over here? This is an which bleed, arterial bleed or venous bleed? This is also an arterial bleed. Which artery? Middle cerebellar artery. Okay. So here I taught you which is the most common cause of subarachnoid hemorrhage is like trauma. And one more thing, like what happened here, there is rupturing of the Barrett's aneurysm. Barrett's aneurysm rupture. Okay. So what is the best management over here if there is a Barrett's aneurysm? Tell me. Like coiling is the best management. Endovascular coiling. So this is best. Why? Like coiling is the best procedure. No, you need not open the brain and all. And if this fails, if the coiling fails, then you are going to perform craniotomy plus aneurysm clipping or endovascular clipping. aneurysm clipping. Okay, and this is about management of SAH, subarachnoid hemorrhage. Okay, these are all very important, so I have explained it clearly, and in one line I will teach you. This should be go in your revision notes. So EDH, which is going to bleed? MMA, middle meningeal artery. So what is the shape in CT? Biconvex. Management is craniotomy. In subdural hemorrhage, what is going? This is an arterial bleed or venous bleed? Venous bleed. Which? Bridging veins. So how does the CT is looking? Concavo, convex shape or lens shaped. And like what about intraparenchymal hemorrhage? It is like hypertensive bleed. So like if the bleed not only occurs due to the trauma, if it occurs if the BP is not treated, that leads to intraparenchymal bleeding. And what about this subarachnoid? Tell me. Subarachnoid. So what kind of a bleed? Berry's aneurysm rupture or middle cerebellar artery bleed or Berry aneurysm rupture. So how do you treat? Endovascular coiling, on you may do the clipping also, aneurysm clipping. And this is about all the types of skull fracture and bleedings like brain injuries, traumatic, very important. Like you should know these concepts before going to the exam hall. Like all the concepts which I have taught, they have been asked in multiple times. They will be asked frequently asking. So you should know about each and everything about this. And next we move to ICP. ICP is nothing but intracranial pressure. So normally some pressure is present between the in the brain, that is known as intracranial pressure. So in you and me, how much it is present? That is 10 to 20 mm of Hg. Okay. So now, like how this intracranial pressure is maintained. So what do you mean by the CPP? Is nothing but cerebral perfusion pressure. So I repeat, CPP is nothing but cerebral perfusion pressure. So what do you mean by the CPP is the amount of blood that is going to the brain, that is known as cerebral perfusion pressure. So how do you calculate? MAP minus ICP. MAP is nothing but mean arterial pressure. I repeat, mean arterial pressure. So why I'm not writing the full form is like rapid revision classes, no? So like I will be teaching, don't worry, like I will be teaching all the concepts in very simplified manner. That will be very helpful. So how do you calculate this MAP? MAP is nothing but mean arterial pressure. Mean arterial pressure is nothing but systolic blood pressure plus twice into diastolic blood pressure by 3 minus ICP. How much? 20. So if you calculate this, like systolic blood pressure plus diastolic 120 by 2 into 60 by 3 and all, like something you will be getting like 60 to 80 mm of an Hg. So this is a normal cerebral perfusion pressure. Okay. So sorry. So you calculate this, you know, systolic blood pressure, diastolic blood pressure, divide. So this is very important formula. How do you calculate this mean arterial pressure? This itself is an MCQ. Systolic blood pressure plus twice into DBP is nothing but diastolic blood pressure by 3 minus 20 mm of an Hg. So normal cerebral perfusion pressure is between, like if you do all this, like you will get around 60 to 80 mm of Hg. This is a normal cerebral perfusion pressure. And next, in terms of an ICP, so what in, like if the pressure is greater than 25, that are 21, 22, we'll call it that as an ICP, intracranial pressure. So what are all the clinical features that you are gonna get over here is like headache. Headache, why it is occurring? There is a stretching of the dura mater, so that's why it leads to an headache. And next you will get this vomiting. Which kind of a vomiting? Projectile vomiting, which is a jet shaped, no, like very fast, goes too far distance, that is known as projectile. In head injury, almost we know sixth cranial nerve is involved. and the patient get altered mental status. Altered mental status. So remember, this is a most reliable feature. Which altered mental status? So this, on examination of the patients with raised ICP, this point is very important, that the patient, if you examine the patient, is by having bradycardia and the patient is having hypertension and the patient is having irregular like a chain stroke breathing. I will explain you what do you mean by this chain stroke breathing. So all these are known as, tell me, all these are like Cushing's triad. Like we all be seeing, no? Cushing's triad is seen in raised ICP. Cushing reflexes or Cushing's triad. Where you are going to see in raised ICP, bradycardia, hypertension and chain stroke breathing. These are all about Cushing's triad or Cushing reflexes we are going to study over here. So what do you mean by this chain stroke breathing is the person will develop, the person is breathing too fast and later on the person will be too less and next the person will not at all breathe. So look at the breathing pattern over here. Too fast, too slow, no breathing. Hyper, hypo and apnea, no breathing. Fast breathing, less breathing, no breathing. This is known as chain stroke breathing. This breathing pattern is known as chain stroke breathing, which especially we'll see in head injury patients or raised ICP. Okay, and if this condition is not treated, next the patient will go like, first the patient will breathe less and next breathe too fast, less. Here it's hyper hypoapnea, that is like regular wala. Here it is like first you will get hyper and next you will get hyper apnea, like apnea is not present and hypo and hyper, there is no regular path. This is known as irregular breathing. So this is your what it is, Biot's breathing. Okay, and if this is not treated and the patient will go into complete cessation of an breathing, that is known as agonal breathing. Okay, so these are all breathing patterns that you will see in a head injury patients, like chain stroke breathing, Cushing's triad or Cushing reflex, bradycardia, hypertension and chain stroke breathing. Like these are all very important. Hyper hypoapnea, these are all the breathing pattern you will be seeing in raised ICP patients also. Okay, and next I told you, know, posturing, like what kind of posturing if the pressure will increases? No, this is very dangerous. That is decorticate position and decerebrate position. Look at this, decorticate, decorticate. So here there is a flexion in the hands. Look at this, there is a flexion in the hands and extension in the legs. So this is decorticate, flexion in the hands and extension in the legs. Okay, and if the hands are also extended and legs also extended, this is about decerebrate position. So look at this very important, like postures. Don't confuse corticate, decorticate and decerebrate. Corticate is patient is flexing the hand. In decerebrate, complete extension, hands and legs are completely extended. This is about decorticate position and decerebrate position. I think now you know about posturing. And if you look at the fundus in this raised ICP, it will get papillary edema. And these are all the clinical features you are going to see in a raised ICP patient. And how do you manage this? By through head end elevation. And next is you are going to give osmotic diuretic, that is your mannitol is used in raised ICP. mannitol, which is an osmotic diuretic. And next is insert ICP monitor. No, you should be keep on monitoring the pressure. So that is known as ventriculostomy. And remember, all above this, which is an highly effective, this ventriculostomy is highly effective procedure. Okay, this is about raised ICP and management. Very, very, very important for your exams, and please go through this. And next, two scores are very, very important in your career. One is your GCS score and one is Apgar score. Apgar score I have already taught you in pediatrics, and now we will be teaching about Glasgow Coma score, right? So this basically it complete it. This, you should know each and every concepts to like in about GCS. GCS basically EVM. E stands for eye opening. V stands for verbal response. M stands for motor response. Okay. So like we'll be studying each and every parameter, like I will teach you clearly. So first parameter is eye opening. 4, 3, 2, 1. No 0, okay? So if the patient open eyes spontaneously, so then you are going to use score 4. And if the patient, if on command you are telling open the eyes, you tell the patient on command, if you tell the open the eyes, if the patient open, then you are going to give score 3. Like on pain, the patient is opening the eyes, so that is like on pain, like if you are giving the pain on the supraorbital ridges or by pushing on this nail bits, no, so like this, no, like if you give this pain, that is known as supraorbital ridges, pressure on the supraorbital ridges, and the patient opens on pain stimulus, no, you are giving the pain and the patient opens the eye, that is known as score 2. And if the patient's not at all open the eyes, like if you give the pain, if you give something at all, no, is not at all opening, so that is score 1, no response. Eyes open spontaneously, score 4. I repeat all the scores: 4, 3, 2, 1. Eyes open spontaneously, eyes open on command, eyes open on pain, and there is no total response, that is score 1. And next we move to the verbal response, like score 5. Like patient is conscious to whom? Time, place, person. Okay, time, place, person. Time, place, and person and all. If you ask the time, the person will be the time. If you ask the person place where you are there, you will tell. And if you ask the with whom, like if you ask his neighbor or if who brought you to hospital, he can tell everything. That is consciousness. And score 4 is disoriented. Disoriented to time, place is not, is telling like something something. No, if you ask the time and all, like he's like telling something, so like he's not oriented to time, place, that is disoriented. And score 3 is nothing but inappropriate words. Inappropriate words. So if you ask the patient like what is your name, no, he'll be telling like what is your name? Bangalore, Mangalore, Hyderabad, Delhi, Mumbai, something, Rajasthan, Jaipur, something something and all, he will be telling like that. That is like you're asking name and he's telling something something. That is about inappropriate words. And next is like score to compromise of incomprehensive. Incomprehensible words. What do you mean by this incomprehensible? Like the patient, if you ask name, is telling like he's not able to tell that. Previously used to tell like something something at all, and now he'll be like like something is like mimicking. That is oh, like he's not able to speak. That is known as incomprehensible words. Like that is like incomprehensible. And what is the score 1? There is no response at all. This is score 1. And yeah, motor response. Now we move to the motor response. He follows the command. If whatever you will tell, he will do that thing. That is known as score 6. completely fine, follows command. And if you ask the person where is the pain, he will tell that I got the pain over here. That is, he is localizing the pain. He is about to show the pain and all. And what is this 4? 4 stands for normal flexion. So if you ask the patient where is the pain, he can tell my pain is in eye. That is about score 5. My pain is in hand or something and all. And if you ask him, can you show me where is the pain? So he can tell that my pain is in the ears and my pain is in the eyes and also that is like normal flexion. That is normal flexion. You are going to give score 4. And what about score 3? Score 3 is nothing but abnormal flexion. So abnormal flexion is score 3. He is telling like where is your right? So he is going to show you the left. And like score 2 is nothing but abnormal extension. So in exam hall, they will mention decorticate, decerebrate. Tell me, now you are know which is decorticate position. So if they ask, the person has developed decorticate positioning, decerebrate positioning, posturing. So what you are going to give the score? Decorticate, abnormal flexion. I thought you know here abnormal flexion, that is decorticate, and abnormal extension, that is like decerebrate, CEE, decorticate, COR, which I have shown above the images also. This is decorticate and this is decerebrate. And what about 1? 1 is always no response. So this is about Glasgow Coma Scale. I have taught you clearly about all the components. I have explained each and everything. And next, what is the maximum GCS? Is 15. Okay. And what what you tell me if they ask you coma less than 8 indicates coma in the patient. Okay. This is about GCS in the patient. Now I have to so what neurology is very important. Most questions that you can ask if you solve the MCQs, you will be finding more like in terms of this GCS score and all. And next topic is scissors. So very important. Scissors are also very important. I have simplified like all of these scissors in this single slide. I will teach you very important slide suppose imagine. So most of you will be confusing about what do you mean by this seizure, convulsion and epilepsy. So what do you mean by this seizure? Seizure is nothing but abnormal electrical discharge in the brain, abnormal electrical current that is passing in the brain, that is known as seizures. I will teach you. Seizure is nothing but abnormal electrical discharge in the brain, that is your seizure. And what do you mean by this convulsion? Convulsion is nothing but the motor movement, that is you showing this no like violent jerky movements, the movements that is known as convulsions. So like this no, you will be showing this violent jerky movements, that is about convulsions. That violent jerky movements is called what? Convulsion. So what do you mean by this epilepsy? Like if this seizure, no, it is occurring repeatedly, unprovoked seizures greater than or equal to 2 times, that is known as epilepsy. That is recurrent seizures. That is epilepsy. Okay. So I will show you like I have one slide. This slide. So let me teach you first this slide. So seizures, I know. What do you mean by these seizures? Now you guys know like abnormal electrical activity in the brain. So focal is nothing but only one part of the brain, like only one part of the brain is firing too much. Only one part of the brain is firing too much. No, that is focal. And these focal seizures are basically they are divided into 2 types, that is focal aware and focal impaired awareness. So nothing but in one thing, like the patient is aware, in one more thing, one more seizure the patient is not aware. So this is known as simple partial focal seizure. Simple partial focal seizure. No, simple simple partial focal seizure. So what do you mean by this simple partial focal seizure is, look at this, the patient is aware, the patient is aware over here. In the focal seizure, the patient is aware, that is simple. And if the patient is not aware about this, like he got unconscious, is not at all aware, that is known as complex seizure. That is complex partial focal seizure. Okay, so this is about seizure. And in generalized whole body, so generalized is divided into these many types: absence, atonic, myoclonic, tonic, myotonic, clonic, and all. No, so I will teach you. Absent seizures is also known as petit mal seizures. Okay, so this usually it occurs in a children. So if you go for parent teacher meeting, no, like, and all, the teacher will be telling, so your kid is looking like an daydreamer, vacant staring looks, is not at all active and all. No, so they are daydreaming. Very very important point. That is daydreamers, and they are having this vacant staring looks. So all these are precipitated by hyperventilation. So if the child is hyperventilated, you will get this absence. It is also known as petit mal seizure. So what about this in IQ in this patient? IQ is normal. So drug of choice, ethosuximide. Okay, ethosuximide is the drug of choice for absence seizure, or it is also known as petit mal seizure. Atonic seizure. So atonic seizure is nothing but tone is decreased. If the tone is decreased, what will happen? Patient will fell down. No, you will drop, like patient will fell down, lost the tone. And myoclonic is nothing but quick and repetitive jerks. That is known as myoclonic. Tonic seizure, stiffness. No, like the patient is stiffed. Tonic is nothing but stiffness. And tonic clonic seizures, it is also known as grand mal seizures. So that, what do you mean by this? There is an alternative stiffening and movement. So like here post-ictal confusion is not present over here, in where in grand mal seizures or tonic clonic seizures. And this is about seizures one in I have explained. So let's move on to this discussion first. So GTCS is very very important. It's the most common type of seizures in adult. And tell me, so like the patient, so remember there are two friends, and so let's discuss in this scenario based, no, that you will be regaining in a long time. Like there are two friends who goes for same college, and they are all neighbors, and they go for same bus also. Both of them, they had like waiting for the bus in the bus station. In the bus station, what they happened is like one of his friend, no, like both of them are friends. His friend, one of his friend got suddenly he got unconscious. He felt on the road, and he was like completely unawareness of himself. And after 30, 40, 50 seconds, he was completely normal. So remember, most of the seizures, they'll terminate within 30 seconds to 60 seconds, within the 1 minute. And his friend, no, like he took this guy to an hospital, and in the hospital he got his, and he got his consequences, no, and some auto drivers and all, they helped him, and he took this friend to the hospital, and in the hospital he got the consequences. So like he was like aware in the consequences, no, he got aware in the hospital. And he asked like if the, and his doctor asked like, you know why you are in the hospital? And he was like, why I am in hospital? And he's completely, he don't know what are all the movements happened in that duration. Like whenever the patient will get the, he will having this stiffness in the body, and his secretions, no, this pulling of his secretions, he cannot able to secretions will be coming from the body, and he's stiff, and his tongue will go back, and he's biting the teeth and all like this, no, like Remember, like in some most of the people, they will be opening their airway by through the hand, and they'll be putting finger also, no, in the scissors. That is really very very bad. So if you put the finger in the mouth, no, those people, they will bite very hard, and your finger will also cut. So please don't put finger in the person who is having the scissors and all. So like these are all happening. And remember, I will teach you, this is about GTCS, no, unconsciousness and post-ictal and all. So morning he woke up and he was like, I am getting some headache and all. And headache is like you will getting in most of the conditions. And whenever he came to the bus stop, I told he felt. When he felt, his tone get increased. That is known as generalized. All the parts, tonus, stiffness, and clonus is nothing but jerky movements. So all these like jerky movements are, and if you look at the person, he will be having this uprolling of an eye. And I thought, no, secretions are coming, pulling of secretions, and this, no, lips will turn bluish color, perioral cyanosis. And all this occurs in between 30 to 60 seconds, no, like there is chances of an aspiration. And this is about generalized tonic clonic seizure. And what do you mean by this epilepsy? I thought greater than or two episodes of unprovoked seizure. So what do you mean by this unprovoked? We all know, no, in other conditions also we'll be getting seizures, like hypoglycemia also indicates the seizure. So this is about unprovoked seizure. Generalized clonic status epilepticus. So now they have removed this term status and then generalized clonic status epilepticus. Status epilepticus is nothing but if the same, I told you, know, like all the seizures, they'll terminate within the 1 minute. And if the same, like if it continues more than 1 minute or like greater than 5 minutes, that is known as status epilepticus. Okay, status, I repeat, status epilepticus is nothing but the seizures which is greater than 5 minutes. So, like, what is the drug of choice for absent seizures? Ethosuximide. So, what is the drug of choice for generalized tonic-clonic seizures? Valporate. I will be writing over here. So, epilepsy in pregnancy. So, epileptic drug in pregnancy. Tell me which is levetiracetam. And this is not there. You can go for lamotrigine. Okay. And focal seizures, you are going to give phenytoin. So, phenytoin normal range is 10 to 20 micrograms per ml. So, phenytoin in the pregnancy, it will leads to fetal Hydanton syndrome. Okay, very very important. So, what are all the features of fetal Hydanton syndrome? Remember by through the mnemonic MCH. M stands for microcephaly. C stands for cleft lip and cleft palate, and H stands for hypoplastic phalanges. Okay, these are all fetal. So consumption of an phenytoin in the pregnancy, it causes fetal Hydanton syndrome. MCH is the mnemonic over here. And you drug, I have wrote all the drug of choices in this one slide. Very very important. So if they ask drug of choice for GTCS, valporate. Drug of choice for status epilepticus, lorazepam. And drug of choice for febrile seizures, diazepam. And drug of choice for neonatal seizures in newborns, I taught you in pediatrics, phenobarbitons. And drug of choice for atypical absence seizures, valporate. And typical absence seizures. So if you don't remember this atypical also, this is very important. Absence seizures, drug of choice, ethosuximide. And two more points. Drug of choice for trigeminal neuralgia is carbimazepine. And if they ask drug of choice for focal seizure, same, carbimazepine. Okay, I will write it for you. So carbimazepine. Okay, these are all drug of choices for all this. I have simplified these seizures. You know GTCS, you know epileptics, you know absence seizures is, you know, and their treatment also now you guys know. Like phenytoin, one of the side effect of phenytoin is gingival hyperplasia, gum hyperplasia and all. No, and remember valporate is hepatotoxic. Very very important. Like valporate, you should not be given to the age less than 3 years. Valporate is contraindicated in less than 3 years. Why? It is an hepatotoxic. Valporate is an hepatotoxic drug. So this is about seizures and very very important. And now let's move to the some of the this multiply terms known as Broca's area, Wernicke's area, which are present in the air, which are present in the brain and all. No? Like let's discuss about what is the main function of this Broca's and Wernicke's. Broca's and Wernicke's, no? So remember this Wernicke's area that is present in the brain, that is helpful for understanding or comprehension. So this is helpful for comprehension, that is understanding. What about this Broca's? For what it is useful? It is helpful for expression or to speech or for fluency. This Broca's is nothing but बोलने के लिए. बोलने के लिए is in the Hindi term like we used to say, no, like speech or fluency. So this is the function of Broca's and Wernicke's. And between this Broca's and Wernicke's, one area is present that is known as arcus fasciculus. Okay, arcus fasciculus. Remember, if I tell to repeat arcus fasciculus in offline classes, you guys can repeat, no, like arcus fasciculus, arcus fasciculus. If they tell to repeat, so whatever repetition is done by this area, arcus fasciculus, if there is a damage in this area, you cannot able to repeat. So this is the function of arcus fasciculus, that is repetition is done by arcus fasciculus. Wernicke's understanding, Broca's fluency. So between there is an arcus fasciculus, that is an repetition. No, if I tell you to repeat the words, you can repeat. If I tell, that is the repetition is done by arcus fasciculus. Okay, so this is very important. I will show you the diagram. I like cats. No, suppose imagine if a person he like the cats, and if the person this area is developed, Broca's is got damage. So in all the stroke patients, no, we'll be seeing like Broca's area will get damaged, Wernicke's areas will get damaged. I will be explaining you. So if Broca's area will get damaged, tell me what will be happen? Person can understand, but he cannot able to speak. Fluency is lacked. So that's why he is telling I like cats, but I gap kya. He'll be telling like this, no, I cat something like there is, he can tell, but the fluency is lost. So now I am teaching you in an order manner. No, when the fluency is present, if Broca's is destroyed, that you cannot able to tell, that fluency will get lost. And if Wernicke's is get damaged, Wernicke's area is get damaged, so if I tell the patient I want an apple, if he tell I want an apple, no, the person will be telling like this, no, maybe lean something which is not at all correlated. If you want something, no, if you go to the shop and if you tell the shopkeeper that I need a pen, you can tell, no, I need a pen, but this person if they go for a shop, no, they will be telling something and all, no, like I cannot tell I need also, they will be telling like ma la la ba, like something which is all not at all related over here. So that is about Wernicke's area and Broca's area, and very very important. Like one is helpful for understanding and one is helpful for the speech, and arcus fasciculus is helpful for the repetition. Okay, and this is about areas. And now I will teach you some blood supply to the brain and also medulla, pons and all. So write this blood supply with me, that will be very helpful for you. Suppose imagine this is vertebral artery, this is vertebral artery, and here we will get so this is basilar artery, and this is posterior cerebellar artery, PCA, posterior cerebellar artery, and this is your main internal carotid artery, ICA, internal carotid artery, and its branch, one of its branch, that is here. Here this is MCA, middle cerebellar artery, and this is also MCA, right, left MCA and all, and this is anterior communicating artery. So this is like anterior cerebellar artery, and here it is anterior communicating artery. Okay, so this is about diagram. So like these are all like branches and all. Suppose imagine, so this will come over here itself. So this is not separated, these are all like in a chain over here. And this is vertebral artery. Where does it supply? To the medulla. If there is a damage to the vertebral artery, which part? Medulla will get damaged. Medulla is responsible for respiration. And basilar artery, pons. Posterior cerebellar artery, midbrain. And this middle cerebellar artery, so it is responsible where what are all present over here, and your parietal and temporal lobe. Temporal lobe, they supply blood supply to the parietal and temporal lobe. And anterior communicating artery, here it is a frontal lobe. Okay, so like in stroke patients will be seeing the manifestations. No, suppose imagine the clot, I will be teaching the clot from the heart, it will going from here, sorry, it is going from here, is going from here, and it will block this middle cerebellar artery, one of the branch of the internal carotid artery. So which lobe will get hampered, will not function? That is your parietal lobe and temporal lobe. Okay, and if the clot it go for this anteriorly, anterior cerebellar artery, which lobe? Frontal lobe will get affected. Okay, so that's why like atrial fibrillation, like the clot it goes to the brain, will be getting the stroke. No, so like in the stroke, which if the it will get the clot came and lodge over here in middle cerebellar artery, which part will get damaged? Your memory. I will be teaching the functions also, temporal and your parietal, and its anterior communicating artery, like anterior cerebellar artery, your frontal lobe, like it is very important like manifestation. So this is about blood supply. So let me teach you about like handedness and this lobes and all.